I'll now go on to Dr. Rohit, who's going to take us to a more complex area, managing resurgeries, a simplified approach. Sorry, Rohit, for running it so late, but look forward to all your talks.
No, it doesn't matter. Thank you. In fact, I wanted to say that a lot of this has actually already been covered. So you can see my slides.
Yeah.
So talking about complications, a lot has already been discussed. So I'll take on the most important aspect of complications, which is avoiding them. Complications can be by omission, which means misdiagnosis and faulty planning. And of course, it could be by commission, where we have avoidable or unavoidable surgical mishaps. So we'll just talk about preventing complications. The key is to remember the don'ts. Don't operate pseudostrabismus. Do not operate accommodative esotropias. Refraction, check for alignment with the corneal light reflex to rule out pseudostrabismus in a child coming with a possible strabismus. Do complete ocular motility. Do not miss the obliques. Over time, these obliques, even if you align them in primary gaze, if there is a residual oblique overaction, over time that will decompensate and result in a recurrence of the deviation. So a long-term residual or a long-term recurrence is bound to be there if you miss the obliques. Even in partially accommodative, remember, do not operate for the accommodative part, only operate for the non-accommodative or the fixed esotropia. It's important because over time, the refractive error will decrease and the child can go into an overcorrection. Always remember when not to operate in acquired acute presentations of paralytic strabismus. Wait for adequate period of time for stabilization. We have seen late improvement in many cases of traumatic and medical causes of paralysis. So wait for at least 6 months for stabilization of the deviation. More often than not, you may not require to intervene. Often the fault is in our examination techniques. Remember, how to place the prisms is very important. Appropriate positioning, giving proper targets and measuring it repeatedly is important. Faulty techniques result in faulty outcomes. Remember to check for the refractive error. In high refractive errors, you are going to have the amount of deviation being measured differently. So errors are there if there are more than 4 or 5 diopters of refractive error, because looking through the spectacles of large powers, there is a prismatic effect that can result in the deviations being over measured in minus lenses or under measured in plus lenses. Always remember safe limits. There are limits to what we can achieve, and same is true for recession and resections. If you do less than the minimum approved for recession, the effect will be not there. If you do more than the maximum, it goes beyond the arc of contact and the muscle actually acts like a retractor and there is gross underaction of movement. Resections, if you resect more than the maximum, you're actually losing out on myofibrils, which is a part of a weakening procedure also. Therefore, your results are not going to be better. You may actually be less effective if you do more than the maximum that has been recommended. In acquired strabismus, always wait, identify the cause, be sure that it is not going to improve spontaneously. Very often you may have to require to see old photographs to make sure that it was a congenital deviation, because sometimes patients just notice a deviation or parents will notice a deviation. Often this has happened in Duans because the child will not complain of diplopia, and suddenly in some photograph the parents will notice that the eye is not going on the side and they come to you as an acute acquired esotropia, but in truth it is a long-standing or it's a congenital defect. But again, it's important to make sure the etiology behind any deviation. Ask for variability in an adult strabismus presenting. Often it may the myasthenia can mimic anything. In fact, the dictum goes, if you cannot understand the type of paralytic strabismus, it's probably myasthenia. Be sure of your diagnosis. Don't operate inappropriately. Often Duans is confused with a sixth nerve palsy. Duans has been well discussed. It has been discussed that it has been recommended that a small amount of resections you can get away with, but still the normal dictum really is that you should not resect the lateral rectus. And if you confuse it with a lateral rectus palsy and you do a large resection, you're going to land up in major post-op complications. Identify associated problems. We talked about oblique overactions. Identify DVD because the vertical deviations are going to remain post-op. and they need to be operated or managed appropriately. Dr. Prachi has very nicely talked about DVD. So these are all what you can prepare with when you start your surgery. Anesthesia is something that is important. General anesthesia has been discussed. It's important for us to know about local anesthesia problems. You should be sure that the patient is not allergic to the injectable LA that you are giving. In bilateral surgeries, it's important that you do not give him excess amount of anesthesia. If bilateral surgery is to be done, stagger the block, operate one eye, after a bit operate the other eye, or else give infiltrative local anesthesia instead of the retrobulbar block or peribulbar block. Avoid the problem of wrong muscle. Remember, orientation of the globe is very important. It gets distorted, particularly in fornix incisions that I've had a couple of times, the SR pointing out that the muscle looks a little odd and it's probably the wrong muscle that they have hooked. Observe the insertions. The SR and IR have slanting insertions. Except for MR, all recti have associated obliques. So when in doubt, check for these things. Wrong eye, wrong surgery, wrong patient, of course. Make sure repeatedly check the records and display it in front of you when you start your surgery. Check to vision is possible in globe perforations, vitreous hemorrhage, and endophthalmitis. Globe perforations are not so uncommon, and it's important that you use the spatulated needles and, of course, operate under microscope so that you're able to see everything. You should see the tip of the needle as it is going through the passage, through the sclera. Deep passage should be avoided. When there is thin sclera, marfans, or previously operated, you may think of a hangback or a hemming hangback. And the slight give way feeling is the suspicion that there is a perforation. The moment you have a doubt, press for a little while you're operating, dilate the pupil, screen the retina, mark the site of perforation so that you can identify a hemorrhage or a break. And of course, consult with your retina specialist how you can manage if there is a problem. Cryo used to be the earlier modality. Now, of course, you can do a laser. Anterior segment ischemia occurs if you operate more than 3 or more muscles. First day post-op, you'll start seeing corneal edema, flare cells. It's, of course, important not just more than 3 or more muscles, also the general health of the patient. Patients with medical problems, hypertension, diabetes are anyway having vessels that are atherosclerotic, so maybe higher prone to anterior segment ischemia. Do not operate on 3 or more muscles in the single sitting. Try vessel sparing surgery. Plications we've discussed may be less traumatic or less harmful to the vascular supply. Vertical recti have more anterior ciliary vessels but are not backed by posterior ciliary arteries, and older patients may be more susceptible. So obviously, if you suspect, you start oral and systemic steroids and cycloplegics immediately. Usually the patient would recover, especially if it's a young patient. End-off is an unfortunate complication. Of course, it's important to just be careful while you're preventing it, and you can manage it like you would any patient with end-off or a orbital infection. Frequently seen but self-limiting would be suture reactions, hemorrhages, lid edemas, corneal abrasions. Be careful about. Sometimes you miss them and there is a lot of edema next day post-op. So it's important to look for abrasions and Dellens, which usually would heal easily. Dellens are more common with a limbal incision. Acceptable ones would be small under-over corrections, lid fissure anomalies, slight incompetence, and sometimes diplopia and extreme gaze. So this is a case of you can see post-operative palpable fissure difference. The patient initially came with large angle esotropia, but post-surgery, he was only concerned about the fissure difference, and he probably felt that his squint was better than the fissure difference that he had post-operatively. So be careful, particularly when you're operating vertical recti, you may get significant fissure differences in the post-op period. Some other issues like allergic reactions or chronic granuloma to the suture, which are not uncommon. Now, of course, with vicryl, there is not so much likelihood, but sometimes if you leave a large suture at the knot, you may have a significant suture reaction. Usually resolves with topical steroids and antibiotics. Rarely you may need to excise a cyst that can get formed. Something like this would require an excision. Lost muscle, of course, long-standing squints, taut, tight recti. It can happen. We've just discussed as CFUMs, and the medial rectus is the most likely to get lost. Obviously, while the prevention is the only real thing you can do while passing sutures, do not pull, do not ask your assistant to pull too much. Pass sutures early, a little posterior to the insertion, and of course, in thin atrophic muscles, it's very likely. Uh, Usually, I haven't seen very great success in being able to identify and retrieve a lost muscle. So essentially, you may do a muscle transfer procedure later on, subsequently, if required. The other important thing is a slip muscle. Like in this case, you can see the medial rectus was recessed. You can see the severe adduction deficit and widening of the palpebral fissure that occurs on attempted adduction in this case. So it's important to identify that early. You can prevent it by taking suture bites a little behind the insertion or your clamp. Have good long scleral tracts and use a proper surgeon's knot to tie it. Undercorrections, overcorrections sometimes are desirable, sometimes they may not be. You may initially try optical means to manage by glasses, altering the refractive error, or prisms. And of course, if there is significant under-overcorrection or if the patient has diplopia, you may require to reoperate the patient, either using the same muscles or the other eye or other unoperated muscles. Wound gape or Tenon's prolapse can be a problem in fornix. You may required to close it again, go back and close it again. Sometimes it just sticks. But in the early post-op, you need to make sure that there is no Tenon's prolapse because that will result in a cyst formation. So essentially to tell you that while all of us have possibility of complications, it's always important and helps to be prepared. Thank you very much for your attention.
Superb talk, Rohit. That was really, truly amazing. Thanks a lot.